Alors nous avons le temps pour quelques questions brèves avec des réponses courtes.
Okay, so we welcome all brief questions, comments. Well, I would have a question. We talked about late fatigue, 40% after a year after treatment. Have we looked into what happens with cytokine a year later, TNF and so on? Well, yes, we had looked into that. We hadn't found anything, which is not to say that there is nothing to be found. It's just goes to show that dosing cytokines and TNF was tricky. We didn't have kits that were precise enough. So we can't expect hypnosis to help with CRP then. Any questions, comments? Yes, David.
Mentioned the NCCN guideline for fatigue, and I think they're similar to the ASCO ones that MASC actually rejected because they're not evidence-based. And if you took them literally, you would be investigating every patient on FEC-D chemotherapy for vitamin A deficiency and all sorts of other things when it's an expected consequence. Do you know if there is any field testing that's going to be done for these guidelines to see if they are in any way cost effective? Because that's very important. There's a lot of time and money that can be spent trying to chase down fatigue that's untreatable or is already recognized by the physicians or occurs naturally as a course of treatment.
Comments?
C'est sur le coût du traitement, c'est ça? Oui.
Le multi.
Oui, bah. Non, mais je pense que c'est assez. Vas-y, Florence. Non, bah, je pense que effectivement.
Well, I think, indeed, the difficulty lies in applying the guidelines. In France, a lot of efforts were made, in particular in Paris, in the Paris region, by the CAMI. Thierry Bouillet has worked a lot to develop at very low costs for patients. It's often even free of charge. Develop the possibility of, practicing karate or other sports activities in Paris sports centers, and patients with cancer can benefit from that. After 2 years, they've now set a price because it can't be free of charge anymore, but it's going to be 200 euros per year, so it's fairly low. It's actually financed by private health insurances that invest a lot of money because to them it makes sense. It's a project that can have good return on investment. Because it can have clear benefits in terms of quality of life and survival. But all the other approaches, mind-body, there's a problem in terms of who's going to pay for, the hypnosis sessions, acupuncture sessions that are not reimbursed by Social Security. So there would be a two-tier medicine, those who can benefit from it and those who can't. And I don't have any other answers, more specific answers to that. Well, I don't think there's an answer because we don't have any markers. We're looking for biomarkers everywhere, but here there aren't biomarkers, so you have to sort it out. You have to wait and see. Jeffrey, did you have any comments to add?
I guess I thought that when we increase muscle mass in some of our other studies, we would see an improvement in fatigue, and we don't. So it's clear that just changing muscle mass may not be enough. Mm-hmm. Yet exercise has such a consistent effect. I'm wondering if we know the mechanism by which exercise might be lessening fatigue. Any ideas?
I had one thought I wanted to share and one question. In the studies on oral targeted therapy, what can we do to help with fatigue, because apparently assessment is pretty poor and there's no correlation between what patients describe and what the oncologist is going to make a note of in their records. Well, it has to be assessed. Fatigue needs to be assessed, and I was actually looking at all the studies of targeted therapies for kidney cancer recently, and assessment by the patient, that has never even been done. Assessment of their own fatigue by patients. So I think there really has to be a questionnaire that is self-completed. We have to stop trying to use only NCIC toxicity criteria. There's another element, but it's not available in all languages, which is why it's difficult to have an international study. There are toxicity criteria that are patient NCIC toxicity criteria. Maybe that's the way to go. Time for it to be available in all languages. But the medical community that is interested in fatigue should give guidelines on 2 or 3 questionnaires that should be used, a little bit same as what we do on quality of life. And there's one thing that's important as well. What is the minimum difference, statistically speaking, that is clinically significant? What is acceptable? Same as for quality of life, I think. Okay, many thanks. If we don't have any other press